whatever. I do check that out. But,
well, yeah, the folks outside as well. Straight there, but it's enjoy the stuff. That's good. I'll have Dr. Ari and Dr. Alvarez join us up front for moderating.
He will listen. So I'll call him. And
shake the tree so hard.
And Tav is just going because of
being US president, the international president is going
due to our own president last year. His father-in-law and his uncle all are in Patna. That's in Europe. So again, you must have Charleston, you were there. All those people came from India.
Oh yeah.
So this next section is actually concentrated on highlighting a little bit of what's going on in Omaha with regards to local surgery and rural surgical care. So we're going to go with the order that's on our the printed materials. So Dr. Bajaj, and we'll have our two operators up front. I think Dr. Alvarez is in the back at the moment, but Dr. Ari is our is a surgical oncologist at the University of Nebraska and the DIO of the University of Nebraska. Multiple, I don't know how many training programs we have at the University of Nebraska. Hundreds and some live residency programs. So thank you for moderating that program. The first option. Why don't you turn off your yes, if you don't mind, help me moderate.
Hi, good afternoon, everyone. My name is Varnica Bajaj. I'm a surgical resident at the University of Nebraska Medical Center. And today I'll be discussing the global cancer burden, inequities in accessing cancer care, and strategies to address them. I have no financial disclosures relevant to this talk. So cancer is a growing global crisis. These maps show the crude incidence and mortality rates across the world. What stands out immediately is the stark geographic variation. High-income countries have higher incidence, largely because of better detection, but low and middle-income countries account for a disproportionate share of mortality. That mismatch is the key issue. People in resource-limited settings are more likely to die from cancers that are often treatable. The situation becomes even more urgent when we look at future projections. Logan estimates that by 2050, we'll see 35 million new cancer cases annually, nearly doubling from today. Cancer deaths are expected to rise to 18.5 million, again disproportionately concentrated in low-resource regions. This means that unless we address system-level inequities today, the gap in outcomes will widen even further. A Lancet Oncology Commission reported that surgery is essential for cancer control. In fact, nearly 80% of cancer patients will need at least one surgical procedure. Yet, many countries lack the necessary workforce, equipment, and infrastructure to provide that care. This is where inequity truly becomes visible. Additionally, we know that cancer surgical care depends on the availability of cancer surgeons, anesthesiologists, nursing staff, hospital beds, surgical and sterilization equipment, and a basic sustainable business model. So our study aims to assess the inequities in cancer surgical care worldwide using data from Globocan, the IAEA Imagine database, and the Worldwide Development Indicators. The Lancet Commission highlights 9 solutional domains and 8 actionable strategies to address these gaps, and we use those as a framework for our analysis. We stratified countries by world bank income groups and evaluated disparities in cancer burden, imaging availability, surgical workforce, hospital beds, and health expenditure. The Globocan dataset shares the current and predicted rise in future cancer burden for various income groups. The Imagine dataset helped us assess global radiology and nuclear medicine resources, and the World Bank indicators provided insight into workforce and hospital capacity. So these charts show cancer incidence and mortality growth between 2022 and 2050. High-income countries will see around a 38% increase, but low-income countries will face a staggering 150% increase in incidence. Mortality follows a similar pattern. Low-income countries will see more than 155% increase in cancer deaths, compared to a much small increase of 55% in high-income countries. This highlights the urgent need for strategic investment in cancer care, infrastructure, and low-resource settings. Now let's look at the underlying drivers of these inequities. Low and middle income countries have far fewer physicians, nurses, and midwives per capita. The gap in the surgical workforce in 2018 was about 366% in lower income countries compared to the 25% in high income countries. The surgical workforce is critically insufficient, and operating room sterilization equipment, anesthesia services, and hospital beds are all limited. The radiology resources are even more dramatic in terms of variation. MRI, CT, PET, and mammography scanners, and even trained radiologists are all concentrated amongst the upper income regions, as compared to 93 radiologists per million people in 2022 in high-income countries. There's only 1 radiologist per million people in low-income countries. Not surprisingly, health expenditure per capita is lowest in low-income countries, restricting investment in cancer programs. Low-income countries also have a significantly higher percentage of out-of-pocket costs contributing further to the economic distress. So to summarize, low-resource countries face a rising cancer burden, but have limited surgical workforce, fewer hospital beds, inadequate imaging capacity, fragile OR infrastructure, and a much smaller healthcare budget. This is the environment where the majority of the world's cancer deaths occur. The Lancet Oncology Commission developed a comprehensive framework with 9 solutional domains and 8 action items to improve global cancer surgical care. The 9 crucial domains define the framework for strengthening cancer surgical systems. These include emphasizing the central role of surgery and surgeons in cancer care, and outlining the basic requirements for establishing or expanding cancer surgery services. The framework also highlights the importance of incorporating technology in cancer surgery and recognizing the contributions of other specialties that are integral to delivering optimal cancer surgical care. The 8 action items described include improving access and affordability, expanding the workforce, strengthening research capacity, ensuring safety and quality, maintaining continuous professional development, supporting provider well-being, and building resilience during catastrophic events. I have the opportunity now to present these actions one by one and discuss them. So action 1, ensuring equitable access, availability, and affordability of cancer care to all patients. This is done by undertaking robust cost-benefit analysis to assess the value of existing and new surgical practices and technologies, standardizing surgical care practices, uniformly delivering surgical care across all geographic sections, and effectively dispersing surgical care faces of the complexity by creating sustainable surgical care delivery platforms. Action 2 is training the next generation. We need more medical schools, more surgical oncology fellowships, and exchange programs that allow trainees in lower middle income countries to access advanced education. Training must be tailored to locally prevalent cancers. Action 3 is to develop geographically relevant, contextually appropriate, research stratified research platforms that promote cancer surgical research. Early incorporation of surgical skills workshops and the establishment of global research partnerships create a collaborative research environment. The development of the public cancer registries and databases and improving the availability of statistical expertise to conduct high-quality research are as essential as developing regulatory bodies that can guide and oversee ethical conduct of research. Action 4 is to develop a skilled cancer surgery workforce. This includes equitable distribution of providers, expanding training at all hospital levels, developing educational policies that promote evidence-based training, and working in multidisciplinary teams. Action 5 is to implement principles of patient safety, quality improvement, and value-based care. This can be done by avoiding compromising quality metrics to meet quantity-based administrative targets of care, incorporating education into the principles of patient safety and quality improvement, and the training framework. Action 6 is continuing professional development for surgeons to ensure competence aligned with the most current evidence-based practices. Now, this aims at providing avenues and information channels that serve as conduits for new technology, treatment pathways, and changing clinical practices. Giving surgeons the knowledge, tools, and capabilities to explore new technology or treatment practice has this validity to make any required changes and assess cost-benefit ratios, help ensure competence in all domains. Action 7, promoting well-being among surgeons in the cancer care workforce. This includes mental health support, reducing burnout, improving work conditions, mentorship, addressing gender and minority-specific barriers through policies at the government level that destigmatize mental health in the workspace, and in medical licensing board requirements. Developing policies that address workplace-related issues for women, such as maternity leave, and address issues specific to unwanted and minority cancer surgery workforce are also needed. And lastly, Action 8. Establish cancer surgery delivery platforms in the event of global catastrophic events, which we are familiar with. Pandemic, wars, natural disasters profoundly disrupt cancer surgery. Resilient systems, protective supply chains, and international cooperation can prevent care interruption by making information available to civil society and clinicians about cancer services in war zones, natural disaster areas, or during a pandemic. So taking all this in mind, I was curious as a trainee how all of the other trainees can get involved in global surgery. So a little something for them. For trainees interested in global surgery, there are many pathways. Structured fellowships, NIH program training grants, global surgery organizations, advocacy work, and clinical lectures abroad. These programs offer ways to contribute meaningfully to global cancer care while gaining invaluable experience. So in conclusion, the global cancer burden is rising fast where resources are the lowest. But through targeted forceful expansion, stronger infrastructure, improved research capacity, and global cooperation, it reduces inequities in care. Thank you, and happy to take any questions.
I have a quick question. First, as I'm thinking through the resource-limited structures that exist, it almost seems like a situation for triage. In an emergency room, you pick the most serious situation and deal with that. And unfortunately, have to leave less serious situations for later or not be able to address them. So in cancer care, how would we approach that in terms of screening? Meaning, should we avoid screening for diseases that are less likely to be threatening to life and limb and concentrate on those that are more pressing, or how do you approach that? And it seems almost like a little bit of an ethical or moral quandary.
Yes, that's actually a great question. I was fortunate enough to work on a couple of projects in my undergrad with screening platforms, and something we realized is that, while you can triage the disease and see what has a higher mortality of significantly higher progression in disease, it is essential to still be able to provide the opportunity to have more of a screening process and a diagnostic process. One example that I can give from someone I spoke to during a conference this past weekend is like most of the liver diseases in India present pretty late. And while we don't have a specific screening platform, I think just even the knowledge that exists in the community about any symptoms that could be an early target, like the presence of jaundice or someone just having even limited health literacy could be very significant. So when it comes to triage, I think we need to invest in the community, like having volunteers who can kind of spread health literacy, and having the facilities where we can have like mobile vans that can promote screening for diseases and have a faster progression.
I'm not trying to be controversial, but every study I've ever seen usually blames the U.S. for a horrible healthcare system, and we're considered an upper echelon, higher income. And yet our cancer deaths are going up, and this is going up. The despair to me is we are often compared with other poor countries that I'm told again and again they're doing better in medicine than we are. So is the disconnect only rural, or is it the United States? I don't know if someone can explain that to me, but a lot of our rural people have lots of money. They have nice cars and pickup trucks. They live in nice homes. They have good living, so they'd be considered upper. And yet, the disparity demonstrates that you pointed out that we're interested in, that they have a decreasing survival rate. How does that work, where money seems to be one of the defining measures of care?
It's actually a very incredible question, and thank you for actually raising the dichotomy in that situation. So from my limited experience as a trainee, what I've understood is there is a difference between income and someone with health literacy. So while someone has access to a lot of things that you would consider rich, like a good car, good cost of living, it doesn't essentially mean that we've been successful in promoting health literacy in those areas. There was a study that we were working on last year for gastric cancer, where we kind of realized that the rural areas were actually disproportionately experiencing a higher rate of gastric cancer, and that came down to healthcare literacy. Now, when we compare ourselves to other lower income countries, it almost, that situation, we're really focusing on the income, because there's no insurance in a lot of these countries, higher out-of-pocket costs, and more than that, it's the caregiver burnout and their loss of jobs and situation. So I think that's a great point for a future study, where we can remove these confounding factors and actually focus on what actually is going on. Thank you.
I know in breast cancer there are recommendations that are called resource-based recommendations for breast cancer care, and they include screening and where to get the biggest bang for your buck. Are there those in other forms of cancer that are applied internationally? And why can't we promulgate those recommendations more than I've ever seen them promulgated? Most breast cancer specialists don't even know about those recommendations.
That's a really good point. Actually, I do need to go through that recommendation myself to refresh myself. But again, with the recent meeting we were at for surgical oncology, there was something that was brought up that I think Dr. Inequities referred to. But in India, there's an equivalent of NCCN guidelines, where they focus more on resource-limited settings. A lot of the conversations I had this weekend was primarily based on the why don't we prioritize surgery more than these neoadjuvant therapies that are more expensive for patients and accrue a lot of debt long term? So maybe that would be something incredible to compare and see where we have these differences, and if we can kind of recommend those guidelines for more rural areas here. But again, requires a further study, requires a lot of analysis to that extent, but great question.
In breast cancer, one of the earliest recommendations is that women's breasts be examined, and in the vast majority of the world they're not. And so that's why this tumors present as 7 centimeters and eroding the skin.
Absolutely. And I think that's a greater presence and lowering of that.
First and foremost, Ron, a great presentation. It's nice to see someone that has such a level so consistently national level. I just want to answer 2 quick questions about U.S. outcomes being worse than the rest of the world. When you take all the causes of our lifespan, those look less than OECD countries. But if you remove several causes of death, such as trauma and all those, the cancer will blow the rest of the world away. Our outcomes are far superior than nearly all the OECD. So, in oncology, we're doing well. The next one, the BGHR, Breast Global Health Initiative, had a champion called Varnica, which is huge. He spent a better part of his career coming up with guidelines saying that they need to be resource stratified, because for those of us that travel, you go to a part of the world where they say these are the NCCN guidelines, but they're not applicable to our part of the world. So the reason why breast cancer guidelines have been out there so much is then went back, sat in the WHO, reached out to NCCN, and in NCCN now, they're kind of cross-pollinated that, in other words, other disease sites. There's all that not as successful. We did that on the hereditary panel. It was a little hard to say, use a resource sensitive MRI. There's no such thing like that. But anyway, I just wanted to give an answer to why breast test was so widely successful.
Yeah, he has been very successful, and that program had a lot of international advocates as well, which I think made it successful. And I think in many low-resource countries, there are breast cancer awareness programs that have developed from that. So I think that cancer should use that as an example in general.
Good evening.
One excellent presentation. The other, I'm privileged and honored to introduce Kathleen Guinn, who serves as the Senior Research Program Coordinator at Creighton University School of Medicine and Department of Surgery. Katie's going to go over from data to impact advancing rural surgical research. Katie has been a wonderful addition to the Department of Surgery, helping us move our projects from finish to the finish line as well. Thank you.
Thank you everybody for having me. I'm here to talk about Creighton's experience building our rural surgical research program. I have no idea for the filters. So the first question here is why rural surgical research? I think the first answer is there's persistent outcome disparities. There's a 15% gap in all-cause mortality between rural and urban populations. We'd like to close that gap. Unfortunately, it seems that gap is getting wider, particularly amongst working-age adults in rural areas. So, the silence from a lack of research in rural areas reinforces this inequity. If we're not contributing data from these patients to the rural space, or in the rural space, to national databases and the research literature, those inequities won't get solved. The problems will persist. There's a lack of context-specific solutions, so we'll hear later from some of my colleagues on some implementation around the ACA and whether that had a positive or negative impact on access to cancer care. I'll just give you a punchline. It didn't help access for rural patients to cancer care. That's probably because there's a lack of implementation that's specific for rural areas in that case. And this inaction has system-wide costs. We know that when rural hospitals close, those patients have to be seen other places at larger referral or tertiary centers. And often those patients come in at later dates, they're sicker, they have more complications. So these are all reasons that we need to be doing more research in rural surgery. Despite that, there's some significant barriers to doing research in rural surgery. There's, of course, structural barriers, including workforce constraints, a lack of preventive time, a lack of staffing, a lack of research infrastructure, so help with things like biostats or IRBs, and small sample sizes that make it difficult to reach statistical power. But I think the bigger problems come in the systemic and cultural box. So it's the geographic and institutional isolation, and it's also the trust. So we talk a lot in underserved communities and in underserved research about the trust between patients and providers. An additional thing that I think is really important in the rural space that maybe you don't think about or don't talk about is the lack of trust between rural providers and urban providers. So I have an example of this coming from the Leadership and Advocacy Summit last week. Dr. Kathleen and Dr. Albert were on a panel about rural surgery, and a resident got up and asked about taking a job in a rural area because she had been at a large academic institution, and she went to her mentor talking about, can I take this job in a rural area? What are the pluses, what are the minuses? Not only was she not able to be provided mentorship, but they actually kind of derided her for seeking to go get a job in a rural area. And that will stick with her. That'll continue whether she takes a job in a rural area or not. And those inequities will persist, and that causes a lack of trust. So here I'm just going to talk through some of the steps that we've taken at Creighton to kind of help build an interest in a niche in rural surgery. So the first thing we did was take stock of what we know. So we've defined our current resources, we've talked about what we need and what we have, and how we can be creative with what we have to make what we need. And then think about unanswered questions. I think one of the things I always tell residents when they're coming to me kind of just getting introduced to research or just getting involved in research is, what makes you the most angry in your day? That's an excellent place to start for research. So that's my first step. Step 2 would be define your mission. Talk about what you're doing, find a niche. So an example I have here is one of our young faculty members has recently, she's always been interested in surgical education. She wants to figure out how to prepare surgeons to go out and face the rural workforce. And she has developed a real niche around rural surgery and robotics in the rural space. So that's a good one. And then an old adage from Dr. Alfred is treat it like a business. So operationalize, make a plan, make timelines, set goals, but then also know when to ditch a bad idea. Step 3 would be to start small. So we started with several smaller pilot grants. So you'll notice this OWLS, that's a $25,000 grant. It's not a huge grant. But what we got out of it was a paper, a presentation at a national conference, and some momentum. So we did that with a couple smaller grants, and I think that is kind of what started with some early wins to create a ripple effect. I want to stress a couple other things on this slide, which is leveraging those people in your community, especially when you're in a rural environment. A lot of things can happen from people who know people. So leverage community engagement, leverage rural partnerships, and if you're in a rural environment, your contribution to research doesn't have to look like everybody else's. It doesn't need to be a presentation at a national meeting. It doesn't need to be a publication. It can be referring patients to a local study. It can be answering qualitative research or being part of focus groups. It can be contributions to a national database. All of that kind of helps create or alleviate that silence that's creating that inequity. And then my fourth one is keep going, keep the momentum going, maintain regular research meetings, maintain timelines, especially in a place where you're often collaborating over long distances, making sure to create logistical steps and help coordinate that research is really important. Another thing I want to stress here is talking about your work and branding yourself. I think this is a place that surgeons kind of forget, but when you're talking in the rural space or in an under-resourced space, you need to be getting more resources. So always talking about your work helps you garner those resources, and it helps you make connections, which brings me to my next point. We talked about trust earlier. I would say that collaborating early in an under-resourced spot is really necessary. And so here are some of the research partnerships we've developed. These are simply the organizations we've partnered with. We have a much larger network of handshakes and people we've talked to at conferences and people we've had dinners with or Zoom meetings to help us make our work happen. And the two things I would stress outside of here is look outside of surgery and outside of medicine. So Dr. Arafai talked about his partnership with KFOS and our organization and our partnership with Dr. Ali Ibrahim in Kuwait. And his insights into how health systems work is very applicable to our rural environment. And I've seen many places that we need to bring him in to collaborate with us on things in the US and things outside of engineering to come talk to us about how to implement his way of thinking in the healthcare system. And then one of our major things to do in kind of helping bridge that gap and bring people together was to put together the Creighton CHI Access and Rural Surgery Symposium. As Dr. Arafai said, it will be coming back in April 2027. But this brought together 200 rural interested people in the state of Nebraska. We had Dr. Beth Sutton, who was the current ICS president, as our keynote speaker, but we also had Representative Don Bacon, who was our local congressperson from Nebraska, to come talk about policy and advocacy. This was right about the time that the Big Beautiful Bill was being passed, so this was a really interesting, valuable discussion. A lot of surgeons were very interested, a lot of rural health people are very interested in this. It was a great opportunity for us to kind of interface with different people. And then looking forward, this is just kind of a dream I have in my head, and that is a rural surgical research network. So one, I think we need a place that we can remove infrastructure barriers for the researchers in the rural space. So providing centralized IRB, providing biostatistics support, and then also providing training for people who may be in the rural space who want to reintroduce themselves to research, or people who have not as much mentorship available to them. That would be an excellent thing. Two would be to build equitable academic and rural partnerships. So a lot of times, we've talked about the notion of trust before. A lot of times I feel like this is a unidirectional relationship. We're gathering data, we're gathering ideas, and we're not giving anything back to our academic or our rural partners from the academic space. So defining how they can be contributors and how we can give them the due credit that they need is really important to me. Third, just as we talked about that resident at the Leadership and Advocacy Summit, we need to teach trainees that they can contribute to rural research, they can stay active academically if they want to be in a rural environment. I think this would help alleviate some of the issues with the rural workforce. And four, advocating for change. So the World Health Organization estimates that 86% of research doesn't make it to implementation. When you're in an under-resourced environment, you really need to up that, because these research answers can make things more efficient. They make patient outcomes better. We need to do that in a rural environment to close that gap. So, thank you for having me speak today.
Thank you so much, Kate. Excellent presentation. I appreciate all the hard work that you're doing with ideas. Questions for Kate?
I'm sorry, but I always have thoughts.
No, you're good.
Me too. And actually, in thinking about what you're saying, number one, a rural surgeon saved my life, so I'm very, very supportive of rural surgeons. And secondly, it strikes me that what you were looking for rural surgery, training and research is very much what low-income countries are looking for. It's one of their major requests. And you might want to think, and I don't know if you know about the COSEXA program, the College of Surgeries of Eastern, Southern, and Central Africa, but they have a research training program for their members that is sponsored by the AAS and the SUS, I'm pretty sure that's who sponsors it. And they give it every year as part of their meeting for a day, and I think it's been pretty effective. And also, there's a requirement now that if you publish a global paper in like the World Journal of Surgery, it has to have local authors. So I think that, I don't know if you've looked into those areas, but that might be something you'd be interested in.
Yeah, those are great contributions, and I think there's a lot of overlap I've seen in the rural space and global surgery, but also other underserved populations within the United States. My only question on the local authors thing, and maybe like you can illuminate that for me, does that work within the United States or just within global partners?
It works with global partners. I don't think they do that within low-income countries in the United States.
Or low-income, yeah, perfect. That would be an interesting proposal. So.
The question of medical literacy had come up. So my question is, who's in charge of medical literacy to the public in general?
That's an excellent question, and I think no one has a clear answer. Certainly, it's a multifaceted answer. I would say that A, the patient would have some responsibility for their own literacy, but B, I've talked to a lot of rural surgeons, being in the position that I'm in, and a lot of them feel an intense responsibility to educate their surgeons or their patients, and are working to do so, and often kind of feel like they're pulled in different directions and trying to wear all the hats. So I think that's part of the difficulty for them. And then of course there's like a federal government portion of that too that is responsible for fielding information and fielding research that gets out to the world. So I think it's multifaceted would be my answer.
Well, in our general education system, there's a lot of emphasis on reading, writing, arithmetic. I don't hear healthcare in there anymore. You know, by the time somebody's in the fourth grade, they need to be able to perform in such and so with math, and by the eighth grade, such and so with this, that, and the other thing. There's nothing in there about health.
No, that's definitely true, and I think another thing that's under-resourced that I'm kind of thinking about and pondering is not just health literacy around like answers to your healthcare problems, but health system literacy in how to navigate those programs and systems. It's a very overwhelming thing for patients to deal with, and I think often doctors aren't even fully able to wrap their heads around it. So asking patients to do so is kind of a big deal.
And then we have the ever-present half-hour medical program on TV where anything and everything can be fixed within a 30-minute period, no matter how catastrophic it is, or can be discovered no matter how sick or not sick somebody is. That's a serious misconception that the public has, that we can fix everything, whether it just happened outside the door or whether it's been going on for 25 years and now it's got to an irreversible state.
Yes, certainly. I actually think of that as like I don't know if you watch HGTV, but I think it's a similar problem. And it's like every home renovation show is neatly wrapped up in 30 minutes, and that's certainly not the case. And I think we saw great examples of that in COVID when we were trying to kind of figure out the answer, and people were going on the news saying this is the answer. I think that's a hard balance for us to stress is we're guessing, but it's informed guessing.
And we still have that innate fear of people do not want to go to the doctor because they might find something really wrong, even if it's a minor thing, they don't know that. And the other thing is, a big segment of the public still seems to think the last thing you ever want to do is go to the hospital because that's where people go to die. I mean, this is stuff that we need to overcome.
Yeah, and I'm not sure I can fix that today, and I'm not not sure any of us could fix that honestly today. I think that's a long-term trust issue. And I think a lot of it has been walked back in recent years, and we need to just continue providing excellent care every visit you have with all of those people, so they have someone that they can go to and trust in their local community.
Close with Dr. Turner.
Yeah.
Well, I want to echo what you said. Every traumatic thoracotomy I've seen on any TV, the next day they're sitting up in a chair without being intubated, and they go home the third day. So what are we doing wrong that they're doing right on TV? My comment is only about what you said, where the communication from the academic center to the rural area is there, but doesn't seem to be reciprocated, or what can we find for avenues to engage our rural surgeons, which also might lead to better competency. And some ideas might include the availability of your rural surgeons to perhaps participate in, God forbid, M&M or Grand Rounds, and it can be done easily now through Zoom. It's something that we do in our community. Another might be giving that doctor, and it's something they covet, just are wonderfully happy about, a library subscription to the medical library, because as you all know, trying to get a journal online, oftentimes 50% of the time you're paying for that, but if they're a member of your library, it actually opens the door to further education. And then lastly would be providing them with CME in some fashion, and again, that's become even more complex as everything now has to go through ACCME, and there are modalities to do that. So those are just some ideas to think about, and looking forward to working with you, Katie.
Yeah, absolutely. Thank you, Dr. Timmerman.
Thanks again, Katie.